हाँ नीरज, सबसे बात कर लो एक बार।
हाँ सर, बात कर ली है। वहाँ से तीनों डॉक्टर त्यागी जी हैं, राजेश शर्मा, हेमंत मल्होत्रा और मेरी 5 मिनट पहले ही बात हुई है। तीनों
ठीक है।
ज्वाइन कर लेंगे। लेकिन त्यागी जी है कि यार मैं ओपीडी में रहूंगा। हमने कहा ठीक है सर, आप लॉग इन कर लीजिए।
अच्छा ठीक है।
और बस ये 3 यहाँ आगे हैं, गाजियाबाद के।
ठीक है, मैंने ज्वाइन कर लिया है।
अच्छा,
ठीक है।
ठीक है, मैं भी करता हूँ ज्वाइन।
गुड इवनिंग अमित जी।
गुड इवनिंग मैडम।
गुड इवनिंग अमित जी।
गुड इवनिंग मैडम।
कैसे है?
मैं अच्छा हूँ, आप कैसे हैं?
आई एम गुड। सिचुएशन कैसा है वहाँ पे अभी?
कंट्रोल है।
अच्छा, ओके ओके।
कंट्रोल है, तो काफी कंट्रोल है।
यस यस।
करते हैं, 15 मिनट है मैडम, अभी इन लोगों से बात कर ली है तो इन फ्यू मिनट्स दे ऑल आर ज्वाइन।
राइट, यस।
हेलो। हाँ हाँ, बहुत अच्छा। हेलो। हाँ, कौन से डॉक्टर सी के शर्मा से बात हुई थी? ऑपरेशन के लिए बोल रहे हैं, गंगा राम ऑपरेशन के लिए बोल रहे हैं। Sir, good evening. Sir, your voice is not audible. Chetan,
Sir on mute actually.
आप
I
भेजो
think
जरा
sir is
request.
sir is speaking on call now.
हाँ हेलो गुड
Hello, sir. Good evening. How are you, sir? आजकल आपसे वैसे मिलना नहीं हो पा रहा. दिस इज द वे जहाँ पे मुलाकात हो जाती है, सर.
हाँ नहीं सही कह रहे हैं आजकल तो मुश्किल ही हो रहा है सबका मिलना मतलब द लास्ट 2 मंथ्स है अप्रैल और मई तो काफी मतलब रियली टफ टाइम फॉर एवरीवन।
यस सर.
और आप सब लोग कैसे हैं?
मैं ठीक हूँ सर. घर में सब लोग ठीक है.
वैक्सीनेट हो गए हैं?
नहीं सर, अभी स्लॉट नहीं मिला.
वैक्सीनेट कराओ भाई जल्दी से जल्दी।
नहीं, मैंने सुना है सर कोलंबिया में हो रहा है पेड, तो मैं वहां पे
हाँ
जाके कराऊंगा.
अब तो स्पुतनिक भी आ रही है
यस यस.
तो प्राइवेट में तो स्पुतनिक मिल जाएगी तो आई थिंक वो भी लगवा सकते हैं।
हाँ, तो मैं पता करूंगा कल सर कोलंबिया एशिया में.
बिल्कुल लगवा लेनी चाहिए। खैर अब तो पीक तो चला गया है लेकिन अब वी डोंट नो कब नेक्स्ट पीक आ जाए,
यस यस यस.
है ना। और बताइए
प्रिकॉशन.
क्या है आज का प्लान, क्या है टॉपिक का?
आज का सर वही है जो मैंने आपको भेजा था.
रोज़ोवास्टैटिन।
रोज स्टेटन सर.
ठीक है तो बेसिकली डॉक्टर कौन कौन है? डॉक्टर प्रहलाद है ना?
डॉक्टर प्रहलाद चावला है सर, गाजियाबाद से.
हाँ उनको तो
एक
मैं
है
जानता हूँ डॉक्टर साहब को।
डॉक्टर हेमंत मल्होत्रा है सर, ये कैलाश हॉस्पिटल में है.
हेमंत मल्होत्रा, हाँ इनको भी मैं जानता हूँ। ठीक
जी.
है मैंने एक दो इनके साथ टॉक्स अटेंड किए तो डीएम कार्डियो है शायद।
यस यस यस.
ओके डॉक्टर चावला को भी जानता हूँ। ठीक है।
एंड डॉक्टर अजय रस्तोगी, फोर्टिस,
नोएडा।
नोएडा.
अच्छा ठीक है।
एंड एक डॉक्टर राजेश शर्मा है, इज ए कंसल्टिंग फिजिशियन, कैलाश हॉस्पिटल.
अच्छा और स्पीकर कौन कौन है?
ये स्पीकर है सर, आप मॉडरेटर हैं.
अच्छा ये चारों स्पीकर्स हैं।
ये चारों स्पीकर हैं, आप मॉडरेटर हैं सर.
ठीक है चलो दैट्स गुड।
बस सर थोड़ा सा वेट करते हैं, लोग जो
ठीक
लेने वाले
है।
हैं.
Rajesh sir, can you hear me? Sir, you are on mute.
सर गुड इवनिंग,
Yeah, good evening.
कैसे हैं सर?
I'm fine.
आई थिंक यू आर ड्राइविंग.
मैं क्लिनिक से घर जा रहा हूँ एक्चुअली.
ओके ओके ओके, नो इश्यूज.
आप मेरा ऑन है, कनेक्टेड है, चलने दीजिए.
ओके 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 सर, बस अभी फ्यू मिनट्स में स्टार्ट करें.
हाँ हाँ ठीक है, ओके डन.
हेलो.
हेलो सर, गुड इवनिंग.
गुड इवनिंग.
कैसे हैं सर?
बढ़िया एकदम. बताओ.
बस सर कैसा चल रहा है? कोविड
मैं
थोड़ा पीक कम हुआ नहीं?
हैं?
पीक थोड़ा कम हुआ कि नहीं हुआ सर?
बहुत कम हो गया, बहुत कम हो गया. नमस्कार. आलोक अनुराग ने ज्वाइन किया.
यस सर, डॉक्टर अनुराग सर हैं यहाँ पे. डॉक्टर राजेश शर्मा है नोएडा से सर. एंड डॉक्टर हेमंत मल्होत्रा इज अबाउट टू ज्वाइन.
और किसने ज्वाइन कर लिया है?
डॉक्टर राजेश शर्मा सर, इज फ्रॉम नोएडा.
अभी जो है अनुराग.
हेलो बॉस, डॉक्टर
हेलो.
साहब, how are you?
क्या हाल?
बढ़िया है बॉस.
तो जमाना बीत गया शक्ल देखे हुए.
जमाना बीत गया, बस सही
जमाना,
है.
मतलब ये 1-2 साल तो ऐसे ही निकल गए. इससे वैसे भी मुश्किल से ही हुआ पड़ा था.
स्क्रीन में ही देखने को मिलता है.
स्क्रीन पे
सही
देख.
कह रहे हो, बस तो स्क्रीन ही रह गया है.
चलो कम से कम कुछ तो है.
हाँ, ये बात तो सही है. आज से
बहुत, मुझे तो लगता है ये बहुत अच्छा है. अगर लोगों को पढ़ने के पॉइंट ऑफ व्यू से अगर उसके लिए चाहिए तो इट इज वेरी गुड प्लेटफॉर्म. कि आपको 1 घंटे में आपका काम, न जाने का चक्कर, ना आने का. जितनी देर की लेक्चर है उतना टाइम आपको निकालना है. कोई मुश्किल नहीं है. नहीं तो वहां जाओ, ये करो, वो करो. तो
और फिर आप वो सारा प्रोग्राम, अरेंजमेंट, डिनर, सारी दुनिया भर की चीजें होती हैं.
वो हेल्थ हैजार्ड है.
हाँ, हेल्थ हैजार्ड था वो सब.
अगर जितनी फ्रिक्वेंटली मीटिंग होती है वो हेल्थ हैजार्ड है. वो भी एक, मैं तो बहुत खुश हूँ.
नहीं
बाकी
सच
का
में
मुझे पता नहीं है बट आई
नहीं
एम
अच्छा है,
क्वाइट
सही कह रहे हैं आप।
लेकिन अभी लोग वो हुए नहीं है, ओरिएंटेशन नहीं हुआ। जैसे अभी हमने RSSDI किया था तो हम लोगों ने तो बहुत उसको अपने तरफ से मास लेवल पे अच्छा करने की कोशिश की, बट लेकिन मैं देखा एक तो खैर कोरोना का चक्कर पड़ गया, कोरोना उस समय पीक होना शुरू कर गया था एकदम से बहुत ज्यादा, तो उसकी वजह से भी लोग टाइम नहीं दे पाए। खैर फुल डे कॉन्फ्रेंस में थोड़ा मुश्किल होता है, बट लेकिन एक है तो ये अपॉर्चुनिटी तो है ही है अपने आप में, अगर लोग यूज करें। चलिए खैर जो भी है।
और अमित जी शुरू करें।
करता हूँ सर। डॉक्टर अहमद मल्होत्रा ने भी ज्वाइन कर लिया है।
हाँ कर लिया है मैंने।
सर गुड इवनिंग।
गुड इवनिंग अनुराग जी, गुड इवनिंग परिचय।
सर डॉक्टर
प्रहलाद,
अहमद मल्होत्रा कैलाश हॉस्पिटल
Yes,
नोएडा।
नमस्कार
yes.
सर।
नमस्कार।
मैं अभी
नमस्कार
कार
सर।
ड्राइव कर रहा था एक्चुअली।
नमस्कार।
नमस्कार
डॉक्टर
गुड
राजेश
इवनिंग
शर्मा
सर।
इज फ्रॉम नोएडा सर।
हाँ जी, हाँ
गुड
जी।
इवनिंग सर।
मैं कार में था एक्चुअली, बस क्लिनिक गया था कुछ देर
मेरा
के लिए।
वीडियो नहीं आ रहा, पता नहीं।
हाँ सर, वो
चेतन
मैं
कैन
कार
यू
में रखा
हेल्प?
हुआ है सर
नहीं
एक्चुअली।
नहीं, हो गया हो गया हो गया।
ओके ओके।
हम्म।
So sir, we should start.
Yes.
So on behalf of Alchem Laboratories Limited, India's fifth largest company, I Amit Sharma welcome our eminent doctors who have joined us. Eminent doctors who have joined us for today's panel discussion titled Galaxy of Experience with Rosuvastatin. At Alchem, it has always been our endeavor to partner with healthcare professionals and will be continue to do the same even in these challenging times. To help us navigate through the meeting, we have with us today Dr. Anurag Singhal will be our moderator for today's panel discussion. Dr. Anurag Singhal is a leading cardiologist of Ghaziabad, and we take this opportunity to welcome moderator of the day, Dr. Anurag Singhal. And also, I would like to introduce and welcome Dr. Prahlad Chawla, is a leading consulting physician of Ghaziabad. Also, I welcome to Dr. Hemant Malhotra is from Kailash Hospital, Noida, and Dr. Rajesh Sharma is from Kailash Hospital, Noida. Welcome all our panelists and moderators, sir. So I would like to invite Dr. Anurag Singhal to set the context and start the panel discussion. Please, sir.
Yeah. A very thanks to the Alchem team and for inviting me and making me a part of this conclave. And I would also thank my dear colleagues and seniors for being a part of this program. And we all know that the COVID pandemic has really swept our lives in a really unprecedented manner. And we all are affected so much that being a cardiologist or a physician, we all are involved in managing COVID patients to some or the other extent. But at the same time, we should, and we are really understanding that chronic diseases are there to take their toll, and they would definitely be there to harm the human beings as usual. And in chronic disease, we have these hypertension, diabetes, and dyslipidemia, and on the top of it, their complications. So it remains of paramount interest to set the tone and maintain the momentum to reduce the complications of these chronic illnesses. And for that, I think one of the major risk factors for what we call as ASCVD is dyslipidemia. We usually treat the major risk factors for ASCVD, that is diabetes, hypertension, dyslipidemia, and other risk factors. But I think the most ignored is dyslipidemia. So this is the third silent risk factor, and all these are silent, be it diabetes, hypertension, and dyslipidemia. But in my practice, and I think you all would agree, we are using or we are underusing the treatment of dyslipidemia to the greatest extent. Statins, we know from times immemorial, I still remember from my MBBS days, we say that statins are very good and statins should be used. They are the panacea for dyslipidemia and heart disease. But they are grossly underused. And at the same time, there are guidelines which are more aggressively advocating statins and other non-statin treatments for dyslipidemia to decrease the prevalence and complications of ASCVD. So it's high time that we should discuss what is the current guideline for dyslipidemia, what are the favored statins and statin combinations, and what are the role of statin in diabetes, and how we can overcome the inertia at both the patient level and the doctor level, so that our patients are benefited in a proper manner at the right time. So I would like to start the panel discussion. And is there any speaker for that, or we would just like to start like this? You are
Share
muted.
some slides, and you can also start like this also.
Yeah, I think one of us should speak about the slides so that we can then discuss it.
Okay,
So
sir.
generally, we can do a panel discussion also, just your views on your day-to-day
Keep
practice.
commenting with the
and-
slide discussion. Actually, if we present some slides, it will be easier to us what we are going to discuss. So, in my opinion, slides, if we can have 4-5 minutes discussion, so that we keep on ball rolling and discussion will
Yeah.
go
And
ahead.
Yeah, I do agree with you, Prabhasar. लेकिन just हमने जो रखा हुआ है, this is for an panel discussion on the top 4-5 topics only, and yeah, you can share your day-to-day experience in that. Amit, can you
Okay.
present the slides, the topics which we are having?
Yeah.
Just a minute.
Okay, in meanwhile, we can just start the discussion. So I would request each of you to give their experiences. First of all, we would start, what are your experiences in Dr. Prahlad, because you are a renowned diabetologist. What are your experiences of giving statins and initiating statins in diabetic patients? And how do you manage these patients of diabetes, early diabetes or late diabetes with ASCVD with statins and other medicines?
Thank you, Dr. Anurag. As you know, diabetes itself is a cardiovascular risk. So whenever a patient is diabetic, considering the risk profile of the patients, as per the recommendations, I go by the recommendations only. And I try to recommend for every patient of mine above 40 years, whatever may be the LDL levels, I usually prescribe statins. So for my opinion, to my patients, although it's sometimes it has become very difficult, because patients used to say, my cholesterol is normal, then why you are prescribing it? And sometimes it becomes very difficult to convince the patients what is the reason behind it. But in most of the prescription, even with the diabetologist, sometimes I see, even with the endocrinologist, I see the prescription, there is no statins. But reason being, the endocrinologists have no time to convince the patients why there is need for starting statins. So it's really a time-consuming task, but I try to convince my all patients to begin with whenever there is indications. And suppose a patient is already having another risk-enhancing factors in him. Suppose patient is having microalbuminuria, then your risk further increases. Patient is having nephropathy in the form of EGFR is less than 60, then it is further increasing. Patient is having retinopathy, neuropathy. So these are all risk-enhancing factors. So whenever these comorbidities associated with diabetic patients, one should always think of prescribing statins. That is what I used to follow.
Wonderful, very well said. And it is really tough, I think, to convince the patient. Well, I really lie to my patients. I don't say that is a cholesterol lowering drug. I say this is a cardioprotective drug. So perhaps it's a partial lie.
Yes, it's a good, because whosoever comes to you is already in the mind, heart is gadbad, to heart batate hi, it becomes easier for you to convince. But हम लोगों के लिए थोड़ा सा patient को लगता है मुझे heart की दिक्कत नहीं है, and मेरे को I don't have the problems of any cholesterol is normal, then why I should take? For you it is definitely easier. Endocrinologist is definitely difficult. For physician, it is definitely difficult.
Dr. Hemant sir, please.
Yeah, because as the American Association of Clinical Endocrinologists has already stated in 2019, according to the guidelines and guidelines of the AHA also, in diabetic patients, you have to start whatever is the level of LDL, and whether, because the lower, as we all know, that the lower LDL is better, means if it is lower than 70 also, then it is much better. It was found that in some animals, that the animals which are producing no LDL or not at all, are not at risk for atherosclerosis, means they progress but very slowly, and it was suggested. And according to the American Association of Clinical Endocrinologists, what they suggest, that patient with type 2 diabetes with high risk factors. High risk factors means patient with established ASCVD. ASCVD means the patient is, if the patient is having a previous MI, if patient had any angina or CKD or peripheral vascular disease or any target organ disease or anything, then you have to start the moderate intensity statin always, because you have to bring down the LDL level below 70. And as you all know that diabetic mellitus with ASCVD, if the risk is less than 7.5%, then and the age is more than 40, then you have to start with the moderate dose intensity. And if the LDL is more than 70 milligram per deciliter, then you have to start high dose statin in a patient. And if the ASCVD score is more than 7.5, then you have to start high dose statins according to the condition of the patient.
Wonderful, Dr. Hemant sir. Sir, I would also like to ask, which is the statin you would prefer in your diabetic patient? Do you have a choice of atorvastatin versus rosuvastatin, or you think both are equal except potency?
No, sir, because rosuvastatin has been proven to be better than atorvastatin, and it was proved in the trials also, and CTT meta-analysis also. And so rosuvastatin means even moderate intensity 10 to 20 milligram is between 10 to 20 milligram is better than atorvastatin, and it's always better to use rosuvastatin.
Yes, sir. Thanks a lot. So we can conclude that in diabetic patients, irrespective of their LDL levels, each and every diabetic should be given the benefit of statin therapy. The question which arises is when to give moderate intensity and high intensity statin therapy. Perhaps moderate intensity statin therapy is to be given to each and every diabetic patient. But if we have higher risk factors such as proven ASCVD, complications, target organ damage, or a patient of long-standing diabetes, or if the patient is having, you can say the patient is of multiple cardiovascular risk factors and a premature history of cardiovascular disease in the parents, then it is very, very important to give high-intensity therapy. What I think we all have learned over the years, that the statin therapy, apart from its initiation, it is the dose that is important. And moreover, we have seen that most of the doctors, unfortunately, don't use the prescribed dose. If we are using statins, we are giving atorvastatin 10 mg or rosuvastatin 5 mg. We are trying to titrate the LDL levels below 100, which is an outdated concept. Now, the concept in diabetic patients is statin in each and every patient. And of course, as sir rightly pointed out, rosuvastatin is superior to atorvastatin, and at least in primary prevention, we have seen there are multiple of trials, be it Jupiter trial or many trials, which has shown that rosuvastatin is a proven therapy. So the dose of rosuvastatin is moderate intensity is 5 to 10 milligram and high intensity of 20 to 40 milligram. So please, you can increase make it full slides, Amit. Yeah. So this is very important, intensity, and we have discussed intensity. Dr. Chawla, I would like to request you, sir, what are your experiences in rosuvastatin and atorvastatin in different types of patients? And do you find any difference apart from the potency and apart from what we have discussed in trials, any adverse effects or anything like that, and your preference for which type of statin?
I consider both the things safe, but sometimes when the patient is with the CKD, there is a little constraint in using rosuvastatin, because you have to change the dose of the rosuvastatin. Suppose you have prescribed the high dose statins with this high intensity statin with rosuvastatin, and patients land up in the CKD, then definitely there is need to reduce it. For that point of view, when I consider age of the patients and likelihood of having the CKD kind of things, I usually prefer atorvastatin over rosuvastatin. Otherwise, rosuvastatin is very good in terms when the patient SDL is lower side. I have seen with the rosuvastatin SDL tends to increase, but with the rosuvastatin I find it is either no change or there is a little downward trend. As per my experience, although literature says it may increase with the both, but the rosuvastatin I definitely observe these things. There is slight increase in SDL. So both the things I favor. I usually strategize according to my patient profile which statins to use, but definitely with the as trial, just Jupiter trials, which was specifically designed for studying among the elderly. It was found favorable things, although except if you consider the dyslipidemia only, not the diabetic dyslipidemia, one or two patients with all those scenes developing diabetes also. But overall, it was a favorable profile with the rosuvastatin. So definitely, rosuvastatin has more robust data of favor as compared to atorvastatin.
Well said, sir. I totally agree with you. Yeah, Dr. Rajesh Sharma is there, I hope. Okay. I would like the opinion of Dr. Hemant, sir. Sir, what is your opinion and your viewpoint and your experience regarding the role of ezetimibe, because it is coming up in new guidelines, and in patients of dyslipidemia, and how do you use it in your current practice?
No, if I found that with the moderate intensity, the LDL level of rosuvastatin, of course, because I'm using only rosuvastatin, atorvastatin I'm not using at all, except in few cases. And if suppose if the target level of the LDL is not reached with the moderate intensity or with the high intensity rosuvastatin, then I use ezetimibe, because before that, because the ezetimibe selectively it's a local acting drug. It selectively inhibits the intestinal sterol absorption and acetosterol absorption, and it decreases the LDL by 18%. So I always use along with the rosuvastatin, along with the ezetimibe. I prefer that drug. And if the triglyceride levels are above 200 and below 500 or below 500, then I always give chance. I don't start fenofibrate. I start with the rosuvastatin high intensity with ezetimibe, and then I consider fenofibrate, because I have seen a lot of problems with fenofibrate in some patients. So first I give this, and then if the triglycerides are more than 500, then I consider fenofibrate. Otherwise, I add on to ezetimibe, as it is a local acting and it is harmless drug, and it decreases the LDL-C by 18%.
Wonderful, sir. And I think you have really put all the points in right perspective. The combination of statin and ezetimibe is perhaps very, very useful in patients who are at highest risk and whose cholesterol levels, especially LDL levels, are not controlled. Obviously, patients with high triglyceride levels also benefit from high dose rosuvastatin, because triglycerides are reduced, and there are multiple trials of fibrates which have shown that the benefits of reducing it's not only reducing triglyceride, it is by which medicine you are reducing, because recently we have this icosapentaethyl ether which have shown that reduction of triglycerides is beneficial, but unfortunately fibrates have not shown such benefit. Perhaps statins are overall beneficial if they are able to reduce triglyceride apart from reducing LDL levels. Nowadays, we have also PCSK9 inhibitors, which are coming up in a big way in patients who have the highest risk of ASCVD and they have uncontrolled LDL levels. But I think in clinical practice, it is still difficult because of the cost issues which are involved. And the cost effectiveness is still not very good at this point of time. Perhaps in a couple of years, I think we would be able to incorporate PCSK9 inhibitors into our clinical practice more commonly. So, Dr. Chawla, I would like to request you to please give your opinion regarding there's a huge subset of patients over 40 years of age and 75 years, below 75 years of age with an LDL between 70 to 190. And this is what the guidelines say. We have an LDL more than 190, we can use statin straight away. We have LDL less than 70, limited indication of statin except in sub high risk subgroups. But if an LDL is between 70 to 190, we have a huge Pandora's box. And this is something in our clinical practice, we see 99% of patients in between this. And how do you approach these patients, taking consideration of their 10-year risk and other factors? And what is your opinion of how aggressive statin therapy should be initiated in such patients?
For every patient, ASCVD risk has to be assessed. And now it is easier to get assessed with the simple ASCVD plus app is available on, one can download in their smartphone and easily can assess the risk score for every patient. And it's definitely, if the risk score is in the moderate category or the intermediate category, depending upon that risk score category, one can initiate and decides how intense he has to go for the statin therapy. So always, it's not only the LDL level which is important. There are other factors which assessing the risk, patient's comorbidity, things like hypertension is whether there or not, what the patient is tobacco abuse is using or not. So there are so many things which has to be taken care of while prescribing statins, and along with the risk reduction. This is the best criteria to start is ASCVD risk score, and patient that can be easily assessed, and accordingly one can decide the therapy. If it is up to 27, between 7.5 to 20%, then moderate intensity statins are sufficient. If it is more than 20%, then we should go for the high intensity statins therapy.
Yeah, very well said, sir. Dr. Hemant, what is your take on this large group of patients and how to evaluate and move ahead in such patients?
As the Dr. Prahlad has rightly said, and apart from this, I always advise also sometimes the calcium, the coronary artery calcium, if it is according to the score, I just combine with this and then start. Then means then consider it, because then if the coronary artery calcium score is more, and if it is more than 7.5, if the ASCVD risk is more than 7.5, and between 7.5 and 20 is moderate, it's intermediate, and high risk is about 20. So between when the score is more than 7.5, so I usually ask the patient to get to go for the coronary artery calcium score, and if it is more than 100 or something, then I start moderate or high intensity statin as well. And it depends on the so many other factors also. Just like along with the lipid profile, I just take the history of the patient. If there is a family history of ISD or premature death in the family male members, and in the if the patient is having psoriasis or rheumatoid arthritis in South Asian ethnicity, it was found that because the ASCVD is much more, and it may cause problems also. And then other factors also, metabolic syndrome is there, obese patient, then ankle brachial index also, and I observe for that, and then accordingly I decide it. And along with the CRP level, HSC, high sensitivity CRP level, I just advise, and if the LPA is more than 50 milligram per deciliter, and ankle ABI is less than 0.9, so means then I consider assess the risk and start according to the condition and with the age, with the risk factors and what patient is having, then I start according to the moderate or high intensity rosuvastatin.
Sir, I totally agree with you, and you have very well summarized how we should go ahead with a patient with what we call as borderline cholesterol levels. But this is a huge group between LDL 70 to 190, and perhaps this is the group which is mismanaged in a very great way. And it is high time that we should understand it is not only the intensity of statin therapy, but it's the duration of statin therapy in a lifetime. The earlier we start, the longer we give statin therapy, the benefit is there. If we are late in starting statin therapy, we have perhaps missed the bus because the atherosclerotic process has been initiated. The patient's vascular beds have been damaged in some way. And so once a patient who is coming up, at least to us physicians or cardiologists, it is our duty to have a fasting lipid profile or even a non-fasting lipid profile would do for an LDL estimate. And then we have to categorize them according to 10-year risk. If the risk is 5%, we can be relatively comfortable of not starting statin therapy unless until they are compelling indications such as diabetes or very high LDL cholesterol levels or a premature history of cardiovascular disease. But once we have a 5 to 20% risk, then we have to go for this, what you rightly called risk enhancers. And if we quickly and seriously look at this, in Indians, we are harboring many of them, be it metabolic syndrome, be it ethnicity, high CRP levels, lipoprotein A, and other risk factors such as CKD or metabolic syndrome. And so we need to understand that these patients are candidates for statin therapy, and we should start them earlier. We should not be hesitant in starting statin in younger patients in 20s or 30s, because these are the patients who will down the lane in 10 or 20 years, they will become full-blown cardiac patients. And if we do not do so, we are probably committing a crime, committing a sin, withholding a medicine with so much effects. So this is my viewpoint, and I really appreciate both of you for giving these points. I would like to ask Dr. Chawla, sir, what are your opinion about the pleiotropic effects of rosuvastatin or statins in management of ASCVD, and what is your take on it?
Yes, pleiotropic effect is really a discussed things, and it is very important from point of view as far as risk reduction in atherosclerotic cardiovascular disease. It's a well-recognized entity. And but if we compare with this atorvastatin versus rosuvastatin, rosuvastatin has very potent pleiotropic effects in the low doses even. But with atorvastatin, it was seen in this effect was seen only in the high doses. So it is very important, and we should always. That is why the high dose is very important. High intensity is very important. If your patient is at high risk category, we should also take care of this pleiotropic effects and always prescribe patients to the high intensity rosuvastatin is very important as compared to the patient with a low risk, because it is a definite entity which reduces the atherosclerotic cardiovascular disease risk reductions.
I think Dr. Rajesh is online.
Okay. Dr. Rajesh Sharma, sir, welcome. And we have been discussing rosuvastatin. I think you are a part of it. I would like your comment on your usage of statins in patients of dyslipidemia, diabetes, ASCVD, and high risk for ASCVD. Sir, please.
Yeah. Yes, it's a proven fact, as we all know, that as a part of metabolic syndrome, the dyslipidemia goes hand in hand with the diabetes and hypertension. So sooner or later, the patient is going to be dyslipidemic. So in every case, it should be the patient from the day one should be counseled. If somehow some problems arise, patient doesn't really agree, you ask him the second time, if you keep on pushing your words, then patient finally accepts it, and he is very much regular with the statins after first or second meet. Regarding the rosuvastatin choice, definitely what I consider it to be something like 3 to 4 times more potent than the atorvastatin. So since we continue with the lower dose of statins, the side effect associated with hepatitis and myalgia associated with statins, they are very less prominently seen in cases of rosuvastatin. So regarding my choice, yeah, definitely I more into rosuvastatin nowadays rather than atorvastatin. It used to be the earlier choice. And regarding counseling part, the patient do accept it sooner or later. No problems arise, sir.
Very well said, sir. I would thank you for your expert comments and your opinion. Dr. Hemant, sir.
Video is not coming, Dr. Rajesh. Video is not coming in my screen.
Actually, sir, I'm into car, so it's dark in the cars actually.
Okay.
No issues. Dr. Hemant, sir, I would like to add on something, and I would like your opinion. We know that statins reduce cardiovascular events. I have been discussing that, but there have been great research on how statins reduce cardiovascular events apart from pleiotropic effects, because they reduce plaque and all that. I would like you to please throw some light on how statins help in plaque regression or modification of plaque, and how the high intensity statin can modify the natural history of ESCVD. Please, sir.
No, as regarding, I want to add one point, one important point to the pleiotropic effect, because statins, they have multiple pleiotropic effects, including the effects on the inflammation and the plaque stabilization. Plaque stabilization means what? Plaque means they reduces the necrotic, the fat in the plaque, and hence it's the vulnerable plaque becomes the stable plaque, and because the fat amount is reduced in that plaque, and apart from that, it improves the endothelial function. Endothelial function means the patient presents with endothelial dysfunctions. It helps in improving the at cellular level to increase the release of nitric oxide, and it prevents hemostasis, and more importantly, it reduces the high intensity, means moderate to high intensity. The rosuvastatin decreases the mean platelet volume. That is most important. Why it is important in means in ACS or in everybody? Because the mean platelet volume is the only marker for platelet activity, and it is decreased, and means this is most important in that. And and high intensity, it reduces the plaque regression by decreasing the fat content into the vulnerable plaque, and as you all know, the vulnerable plaque has a large fat and the thin layer of fibrous tissue, and then in this case the fibrosis becomes more, and the plaque volume, means the fat volume, is reduced. Hence it becomes changes from vulnerable plaque to the stable plaque. Hence it as you all know, it decreases the atherosclerosis also. It helps in atherosclerosis in coronary arteries also. So that's why it decreases the cardiovascular events also. And I mean, this is the way I think it helps.
Very well said, sir. This is perhaps you have clarified all our doubts. We need to understand that statin therapy definitely have pleiotropic effects, stabilization of plaque, and the most wonderful thing which I feel is the regression of plaque. It has been shown in various trials that high intensity therapy regresses plaque in carotid and coronary arteries, apart from stabilization. So this is something which we used to consider as an Achilles heel in the management of ESCVD, and time and again through intravascular ultrasound and other high resolution images, it has been shown that we can reduce the plaque burden, reduce the atheroma volume by statin therapy. And so it needs to be emphasized that patients who have multivascular disease, polyvascular disease, at at high risk of recurrent cardiovascular events should not be denied the benefit of the highest dose of statin therapy, that is rosuvastatin 40 mg or atorvastatin 80 mg, and perhaps rosuvastatin scores over it with the benefits of decreased LDL levels and increased HDL levels, as Dr. Chawla very rightly pointed out. And I would really appreciate Dr. Chawla, sir, for your comments on where do you use aspirin in combination with statin therapy, because it has been always a controversial point of whether to use aspirin as a combination of statin, as most of the doctors do, or should statin be reserved for few of the highest risk patients. Sir, please.
Actually, so always the debatable things while whether we should add aspirin or not. Actually, I always take care as I go as per the criteria of the American Heart Associations or American College of Cardiology. What they say, evidence are in, if we don't have any risk factor of bleeding, only then you can prescribe if a diabetic patient, if not having risk, it's a level 2 evidences. If we talk about the level 1 evidences of aspirin, then only it is for the secondary prevention, not for the primary prevention. So I always take care when patient is already known case of CAD or patient is not at risk of having bleeding, because in old age, it is mostly patients are at risk of having high chances of bleeding. So I usually don't add aspirin along with this statins if my patient is not having previous chances or the previously having the known case of CAD. So for this, I always use it for secondary prevention only. Rarely I think of adding as a primary prevention. Yes.
Dr. Rajesh, sir, your opinion, please.
Hello. Yeah, actually, sir, my opinion is a bit pro towards using the equipment. Only thing that I consider is the age. Once the patient crosses the 50 years of age, as a primary prevention, I add equipment to all the patients who are diabetic, hypertensive, or they might not have the CAD history.
Yeah. Dr. Hemant, sir, please.
Yeah. Diabetes, as you all know, it's a coronary artery equivalent. And yeah, Dr. Rajesh rightly said, if the patient less than 50 with ASCVD, with the diabetes is already a coronary artery CAD equivalent. So I always use aspirin. Whether it's a primary prevention, secondary prevention, we have to use it. But in primary prevention also, the low dose aspirin along with rosuvastatin, I always use in a diabetic patients, because diabetic patients, as you all know, means the patient may presents with MI at any time, and the CAD is 2 to 3 times more common in diabetic patients, as you all know. All other things are also, you know, that peripheral artery disease and all these things. So you have to control the LDL level. And there was a meta-analysis by the Hennekens et al. It shows that the aspirin therapy provided as an additive effect of 24% relative risk reduction of cardiovascular events in addition to the monotherapy of statins. Hence, and aspirin statin therapy means you have to add, because you never know, because in diabetes there's chances of multivessel disease. That's why they present with the TVD at the most time. And you can see Dr. Anurag Singhal, he knows that when we do the angiography, it's a very diffuse disease all over. So means it's in diabetes, the chances of diffuse coronary artery disease is much more. Hence, I always use in diabetic, whether it's a proven established, because there is a hidden CAD you can suspect of. And there was a CTT 2010. That's 1 milligram reduction of LDL will reduce the 22% reduction of cardiovascular events. This was proved in CTT 2010. 1 milligram reduction of LDL. So we had to reduce the LDL below 70, below 70, as low as 5, and because that is important. So in my opinion, in primary or secondary, if diabetic patient above 50 years of age, I don't use unless if the ASCVD is there, established CAD is there below 50, I always use aspirin. But in above 50, I always use aspirin with moderate to high intensity statins to prevent the subsequent cardiovascular events.
Yeah, wonderfully said. And I think it is a very, very controversial topic, and we can have endless debates on this because the recent trials, we should understand that trials and practice are relatively different things. Recent trials have shown that addition of aspirin to each and every patient of either diabetes or elderly have failed to show the benefit risk ratio because the bleeding events are relatively higher. But considering the very, very high incidence of ASCVD in Indian population, we are seeing younger patients in 30s and 40s and very, very rampant uh, uh, rampant prevalence of diabetes. I think it's not a bad idea to start with a very lower dose of aspirin in selected patients as primary prevention, so that we may not repent later on when such patients comes with acute coronary syndrome. This is my take on it, but I think it should be very, very individualized. We should assess our patients and tell them, these patients, that look, I am giving you a blood thinner, but perhaps it may help you reduce the cardiac events.
And
So
I want to correct one thing, sir, because in as I said that in 220, the CTT meta-analysis, I said 1 milligram. No, it's 1 millimole. 1 millimole reduction of LDL-C cholesterol was associated with the 22% reduction of cardiovascular events.
Yes,
1 millimoles. I said by mistake 1 milligram, but it's a 1 millimole reduction of LDL-C.
Ji, sir. Yes, sir. Oh. I would like, sir, Dr. Prahlad Chawla, sir, Dr. Hemant, sir, please, any of the discussion points would you like to emphasize, your clinical practice or your academic practice, which you feel should be discussed at this forum?
I think we have covered each and every clinical points and what we are doing routinely in practice. That's all, I think. And you have rightly said that intimal medial thickness means carotid artery plaque regression in patients. So I think we have covered each and every point regarding statins.
Yeah, Dr. Chawla, sir, you are muted. Please unmute yourself. Yeah.
Dr. Anurag, I would like your attention regarding, is there any concern about the renal safety or there is any evidences which has said use of rosuvastatin may increase little bit of serum creatinine? Is there any evidence?
No, there's no evidence till now.
Sir, I would like to tell, whenever I used to prescribe rosuvastatin and suppose the patient is having a mild CKD or he visits a nephrologist, the nephrologists are very fond of cutting rosuvastatin and shifting to atorvastatin 5 or 10 mg. Now, this is something which led me to research and go into the guidelines and trials. What I found, I would like to share with you. There have been incidences of some side effects with high dose rosuvastatin. But the reason for this is any statin in higher dose, because it is less metabolized because of the CKD, may cause some adverse effects, maybe in form of myalgias or slight increase in creatinine levels. But I think that is because of the potency of rosuvastatin and not as per rosuvastatin molecule. So if we are giving 20 mg of rosuvastatin, that is equivalent to atorvastatin 40 mg, and the side effects in CKD patients would be similar. So perhaps I don't feel any reason for withholding rosuvastatin in CKD patients. The challenge remains the high dose, because these patients of CKD are the highest risk patients. And as far as the cardiologist opinion, they should be given the highest dose of statin therapy. But at the same time, we have to look for the progression of CKD. And perhaps here comes the basically the challenge of titrating these patients to perhaps moderate intensity statin so that they may have a less progression of CKD. But all this is speculative. So we should not withhold these patients of CKD with moderate to high intensity statin. This is my take on it.
So those should be highest tolerable dose.
Yeah, highest tolerable.
Tolerable dose, and
Yeah,
you have to
that's
watch
good.
for means after 15 days you can go for total CPK and total CPK, and you have to just observe it once or twice, and SGPT, and after 6 months also two times the total CPK and SGPT at 15 days after starting the statin, and after 6 months. If the dose are tolerable, means 5 to 10 milligram, 10 milligram is if patient is tolerating well, then you can continue. It will prevent the progression of CKD also, rosuvastatin, in my view.
Definitely, sir.
So Anurag, again one more question. How much importance you used to give to high sensitivity CRP readings whenever you, or apolipoprotein B, in your assessing the risk of the patients? Because nowadays it's very common, we find people are coming with the reports, and every time it is ApoB is raised or HSCRP is invariably raised nowadays. So how much importance in this time of COVID we can give to the HSCRP?
I would request Dr. Hemant sir to please answer this question.
High sensitivity CRP is raised because of so many other factors, but because of inflammation, as I already said, because of the pleiotropic effect. I always, if the patient is having high HSCRP, so I always start statin. And you know that HSCRP is treated, then in that case, then I always start low dose aspirin also in some cases. Because it's a inflammatory process is going on, and because in COVID, definitely because of HSCRP is there, because of cytokine storm and other things going on, because of COVID pneumonia and other things. So we have to watchful. I just start statin along in the COVID patient also. If the HSCRP is raised, and if the means then apart from that, everybody is using anticoagulants. If there is a moderate to HRCT is moderate to severe, then you may be using the anticoagulants, either rivaroxaban or apixaban, or means aspirin or something like that. That helps in preventing the rising of HSCRP. But I always use rosuvastatin, means statin plus aspirin or whatever it is. Then follow up for 1 or 2 months. Then ask him to do HSCRP, and then I may stop if the patient. I may stop aspirin if there are no ASCVD risk or something. But I'll continue with the rosuvastatin.
Yes, sir. Yes, sir. I totally agree. The issue is these are COVID times, and we are definitely seeing patients with high CRP levels. And we should understand that HSCRP and CRP are different things. HSCRP is high sensitivity, so even it will pick lower levels of CRP levels. So a patient who is having high CRP would definitely be having a very high HSCRP. Now the question arises is how to manage these patients. Look, you have to repeat these levels again and again, because as sir rightly pointed out, these are signs, markers of inflammation. So if the patient is having a high CRP or a high HSCRP, as we are discussing, we should restrict ourselves to HSCRP. Then we should definitely rule out other causes of inflammation, such as fever or COVID-19 or many others. If we are convinced that these high HSCRP levels continue to be high, obviously Jupiter trial showed that patients with normal LDL levels and high HSCRP benefit from statin therapy. So these patients with high, but mind it, in clinical practice, perhaps we are underutilizing this, because we have many other tools to determine the usage of statin therapy. And perhaps we are not able to meet the target of statin therapy in these patients. So if we add HSCRP to these, so perhaps I think each and every Indian would be eligible for statin therapy. So we should look for LDL levels if possible. We have to look for HSCRP. Lp(a) is also a very good marker for high risk for ASCVD in South Asian population. Even in patients who have normal LDL levels and high Lp(a), Inas have done a very lot of research in this, and he advocates that we should use statin therapy in these patients also. So there's a huge scope for use of statin therapy in most of these patients, and we should encourage this for statin purpose.
Is there any question in chat box, Amit?
No, sir.
So I think we can conclude.
Okay, sir.
Amit, what do you say?
Yes, sir. Sir.
So I would like to take some few comments from Dr. Hemant sir, Dr. Prahlad Chavda sir, so that way we can conclude then.
I think we have discussed everything.
Okay.
So I think now the means according to ACC AHA guidelines, along if the patient is along with the ASCVD, then you have to start high, moderate to high intensity statins, and according to the condition of patients and according to the comorbid factors, then and then you have to recheck again and again, and you have to adjust the dose of statins accordingly.
Yes.
What I would like to say, physician has to come up from inertia of prescribing statins. Statins are must. They are good for primary prevention of the CAD. So we should go ahead with the statins.
Yeah.
It's very important to every patient, wherever is indicated, one should go with the statins rather than avoiding it or reducing the number, try to reduce the number of pills. And it should be many. I've seen patient if wants to reduce the pills, they reduces this prevention part of the patient.
Definitely, sir.
It's bad. It's a very good drug. It has to be there for the prevention of CAD. Before patients, your patient end up for that and come again with the MI. So statins, right now we have the evidence for statins. If you are not adding aspirin, but the statin is the one which shows for the primary prevention, it has to be prescribed.
In every diabetic patient, it should be the part of the prescription. Whether whatever low is the LDL level, it has to be the part of the statin has to be the part of his prescription. Whatever the LDL and other levels are showing.
Right. So I would like to thank each of you, and I would like to conclude, and I would like Amit to conclude it so that we can leave then.
Yes, sir. So, sir, we take this opportunity to thank Dr. Anurag Singhal, who is moderating the panel discussion. And I also thanks to all the panelists who have sharing their galaxy of experiences with rosuvastatin in clinical practice. We would also like to thank doctors who have joined us for panel discussion, and I am sure you will be appreciated for galaxy of experience with rosuvastatin presented today. We salute our doctors, paramedics who have contributed immensely for keeping us all safe and healthy in these challenging times. We at LKM Laboratories will continue to serve doctors and panelists by making our products available, especially our chronic brands like GP-Rose, Gluvilda, and Orcane. Thank you very much, Anurag sir. Thank you very much, Prahlad sir. Thank you very much, Hemant sir and Dr. Rajesh Sharma sir. Thank you, sir.
Thank you so much, sir.
Good night. Good night, everybody.
Thank you, sir.